Bring the meeting to order. Meeting is called to order, and welcome everyone. At first, I did just want to acknowledge that we are on the traditional lands of the Confederated Tribes of the Colville Reservation, both past and present. They're a great partner of ours here, and we honor with gratitude the land itself and that they are still here. So I want to welcome them. I'm not sure if anyone from the tribe is here. I will go over a little bit of Zoom etiquette at this time. I do ask that if you are able to pull your camera and put it open so we can see your faces. It does help to bring a connectedness that Zoom does. That's the best Zoom has to offer. So also, I will start the board roll call at this time. I have Carlene Anders. Are you here?
Yes, I'm here.
Thank you. Kathy?
I'm here. Thank you.
Deb Murphy?
Here.
Thank you. Dell Anderson? Jesus Hernandez?
Here.
Thank you. Ramona Hicks? Ray Eichmeyer? Rebecca Davenport?
I'm here.
Thank you. Rosalinda Kibbe?
I'm here.
Dr. Tuggy? Dr. Michael Tuggy? Kat Lettet? Teresa Atkinson?
Here.
Hello. Nancy Spurgeon?
I'm here.
Thank you. I'll go ahead and go back to the ones that I missed. Dell Anderson, have you signed on? I know
Yeah.
Ken Sterner is out. Ramona Hicks? And Ray Eichmeyer? Senator Warnock has contacted us that she will be out. Dr. Tuggy? And Kat Lettet. All right.
And Molly,
Yeah.
Wendy put a note in the chat that Bill will be late. He had a conflicting meeting at 1 o'clock.
Perfect. Very good. Okay, I'll watch for him. At this time, I also ask if there's a declaration of conflict that you do so now. Just unmute yourself and let us know of the declaration of conflict. Also, if you are a guest today, if you can put your name in the chat, name and organization. And I ask if there at this time, if there's a public comment from any of the guests. I will ask again at the end, but I just want to make sure that you have a chance to speak up. And then Caroline, if you can bring up the agenda. And I'll give everyone a chance to look it over. It's actually pages 1 through 7 would be the consent agenda, which includes the agenda, acronyms, decision funds, flow chart, and the minutes from the March 7th meeting. And at this time, I would entertain a motion for approval of the consent agenda.
This is Rosalinda. I so move.
Thank you. Do I have a second?
This is Becca. I'll second.
Okay. Having a first and second, is there any comments or questions at this time? Hearing none, we'll call for approval. All those in favor say aye.
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 Opposed would be nay. Any abstentions? Hearing none, motion carried and approved. Thank you. So I will bring on John to do the acting executive director update. John?
Hello, and I just wanted to note that Ramona did join Molly, so I see her in the bottom left corner of my screen. So just a few quick, actually, I'm going to take a little time today to give you some updates on what's going on around the region. I'm also going to spend some time today giving a little recap of some of the one-on-one board conversations I've had with the different board members over the last 2 months, just to give you guys a little bit of sense of what I've learned from those conversations moving into this role. For those of you there's just a few I haven't had a chance to speak to. If I haven't gotten to speak to yet, I am still interested in chatting beyond this meeting, if possible, and if we can schedule a time. So quick state updates. The Medicaid Transformation Project Renewal, public comment for that renewal that starts January 1 of 2023 to 2027 is going to start April 18th. I am going to spend a little bit of time today going over some of the key highlights of the renewal, so you'll see a little bit more details on that later on in the meeting. It is still relatively evolving, so a lot of things we'll talk about today is really mostly conversation based, and then when some of the official documents come out, we'll spend some time on that, or I will also share all that with you guys in regards to the renewal. Last week, the Washington State Healthcare Authority chart team came out to do a tour with some of the hospitals. So they came in on Monday. They met with the NCACH team. They met with Confluence Health, Three Rivers, Mid Valley, North Valley, and then we had a chart advisory council meeting. For those of you, I think I've shared what chart is in the past, but really it's a rural healthcare payment model for hospitals that the Healthcare Authority is working on with an agreement with CMS. It was part of a grant program that the Healthcare Authority was awarded with CMS. I can spend a little more time at some point giving the board a review of what it is. Right now, the hospitals that have signed interest has been Confluence, Three Rivers, Mid Valley, and North Valley Hospital. That does not mean that they are committed to it. They just signed the original letter of interest. And so that is why the Healthcare Authority did a tour with them. I think the biggest benefit out of that tour was the Healthcare Authority getting a chance to meet one-on-one with the different hospitals and listening to some of the concerns they have around the payment model, an alternative payment model with Medicare around rural healthcare payments. CMS, or the Healthcare Authority, for any hospitals that might be interested, is trying to get CMS out here in May to learn more. I should also call out, I know Jesus is on the advisory council as FQHC, and we had the opportunity to have dinner with him and Dr. Lacey one of the nights and gather their input as well. We also had a chance to talk to Raleigh Bolden, who leads the palliative care efforts up in Okanagan County, as well as David McClay, to learn a little bit more around behavioral health stuff. And then Linda Evans-Parlett, our previous executive director, is on the advisory committee. So we also had a chance to catch up with Linda and get to hear some of the things that she has learned or heard around the chart model. I am happy anytime to touch base with anyone if you have additional questions or you want to get a little bit more information on that progress. I think I saw Senator Warnick join.
I did. Sorry I'm late. I have some issues with my video today, so I'll try to do video a little bit later.
Perfect. So I'll give you a quick update on some of the legislation stuff that I've heard. Of course, Senator Warnock will correct me if I am wrong on anything, but some things I've been tracking in the conversation, so I just wanted to update everyone. From what we heard from the Healthcare Authority, there was good discussions around the waiver renewal, but nothing significant came out of it that would cause it to be delayed or not submitted. So everything is going as planned with that. There was a bill that went through the Senate on primary care spending measurement and reporting activities to the Healthcare Trust Cost Transparency Board. So spending time looking at primary care payment. I know Washington State is also implementing or working on the multi-payer primary care model. So it sounds like, or it will look like we'll continue to hear more around primary care payment moving forward in the future. I know some people have been tracking House Bill 1865 around behavioral health workforce and certified peer specialist. That one did not pass through the legislature this year, as well as House Bill 1868, which was looking at staffing needs, overtime, meal and rest breaks for hospitals and medical providers. And I know for our rural healthcare providers and hospitals, this was a bill of large concern due to staffing issues already, and the fact that it would have required additional staffing, and that one also did not pass through legislation. I'm going to admit that this year, I'm not doing a great job giving you guys a legislative update, but if there's ever anything you think is pertinent to this board or the organization, please feel free to pass it along to me, and I'm more than happy to bring it up at any board meetings or any executive director updates. And in the future, when we get a little more organized around policy work, I will hopefully have a little more detail around legislation. I see chats, but I don't know if that's, oh, no, just names in there. Few quick updates around the region. For our Recovery Coach Network, Joey and Wendy are working pretty diligently with Samaritan Healthcare to get an emergency department recovery coach program piloted, and that work is getting underway. I believe they're still in discussions and contracts, but keep an eye out for that moving forward into the future. I heard that and saw a photo that our third Narcan vending machine has made it into the region and is at, I believe it is at Advance, right? Jesus and Joey.
I have not heard, but that would be great if that's the case.
Jesus. Go ahead, Joey.
I was gonna say, yeah, they delivered it at Advance, and I drove up, spent some time with the team, helping set it up, and I delivered a surplus of Narcan to them for the machine.
It was supposed to be, my understanding is it was supposed to be delayed multiple months. And no one actually informed anyone until it was pretty much almost to Advance that it was on its way. So this was like a very, we thought it's going to come in 3 or 4 months. It's coming in 2 hours kind of notification. But we'll take it. It's better to have supply chain 3 months early than 3 months late. And the next NCACH partner convening is coming up April 19th, 10 a.m. to 2 p.m. There's going to be a lot of focus on how we have dialogue between partners, especially having strong dialogue when we are trying to collaborate and come together on shared differences. I know this has been a topic that has come up a lot, even in our governing board discussions when we talk around distributed leadership. And so if you are interested, I encourage you to register. I might ask impromptu one of the staff members if you want to dump that registration link in the chat for me. That would be great. Our next behavioral health learning series in-person session is going to be Wednesday. I don't know why I have February 13th, so I'm just going to defer to Wendy because I have a typo on there to give the correct date.
April 13th.
April 13th. Thank you. So the series is going along very strong. They've had 1 in-person and I believe 3 virtual sessions, and this will be their second in-person session. And at some point, I'll bring along a little bit more detailed update with that. As part of our health equity goal, we have actually been working with the North Central Washington Equity Alliance, and we're contracting with Karen Francis McWhite to help build out how we plan to do some additional board work and engagement around equity and health equity, as well as how we can start tackling some of our 2022 health equity goals. And then big shout out to Joey, Caroline, Teresa, and anyone else on my team that we are missing for the WA 211 Lab and Learn. And so last Wednesday evening, there was a group of recovery coaches, predominantly through the Alano Club, but through the whole Recovery Coalition, that came together to learn how to utilize 211 in the work that they are doing. And it was great because, again, we got to utilize our new space and our conference room. And so you can see a few photos here of the team working together on going through how you can utilize and how you can improve that work on 211. I gotta also give a shout out to Veronica from Action Health Partners, who was, let me know if this is correct, Julia Curley, and she was the facilitator pretty much of the meeting.
Yes, she was. She did wonderful.
And Veronica was actually funded through some of the care coordination and community, our Coalition for Health and Improvement Community Initiative funding that we've had over the last few years. And so that position has really gotten built out. And it's just a demonstration of how some of our funding can go to build recovery coaches, facilitators around the 211 work, and really start to come together and build out some of the stuff that we are doing to support the region. Here's just another great picture to see everyone around. It is nice to see them focused, concentrated. You get to see their focused faces because they're not wearing masks anymore. So you don't know, you get to see what they're thinking. And so it's just great to have people together, learning together in that kind of environment. I wanted to jump in a little bit about the board conversations I've had. So in February and March, I've had a chance to connect with board members, and I really asked them about two primary topics. One was around the current work and the future state work of NCACH, and one was around NCACH board governance. Ultimately, what I've been asking board members is what's been going well, what do they understand, where are their concerns in any of these topics, and what can we do to improve on this work? And it's just been nice to have open, dialogue with each of the board members to learn from each and every one of you. Some of the feedback I specifically got from the NCACH work is overall, everyone understands and appreciates the move to overall health versus just healthcare. One thing I would call out, and that's going to be called out as an area of improvement, is there is disagreement on what it means to do equity work with NCACH and how it relates to our organization. And so that's really a good learning point for us to see how we can get a better understanding of really what that means as a board and what that means as an organization. A few board members need better help understanding the future state work. I think what I'm finding is the further you are from being connected to the strategy work group and the regular conversations, the more and more I'm recognizing it takes more time and more ability to connect with you guys to make sure that you understand where everything is going. It would be helpful to have routine outcome and metrics for board members. Board members have really appreciated the conversations over the last few months, but they also kind of want to understand the timeline of where we are going with this and just see some of the process steps associated with it. And another thing is board members could use some additional help to explain the impact and the work of NCACH to our community. Ultimately, I feel that all of the board here wants to be strong advocates for our work, and they want to know what they want to be able to have the tools available to be those advocates. Around board governance, board format, most board members generally appreciate the format we have. I heard a number of board members like the small breakout sessions, especially when we're on discussion topics versus doing large group discussions. So that's something we will continue to try to do in the future. Board meetings would benefit and the board as a whole would benefit from routine evaluation of how the process is going and how we can continually do better. Some board members recommended keeping an eye on the power dynamics just to make sure everyone feels comfortable contributing at an equal level. Board members need to better understand our committee structure and what it is for. And even board members in those committees feel like they would love better explanation of it. So it's not just those that aren't on that committee. And really, I've heard this all the time. Board members would love to find time to continue to grow and form relationships across the board. So some recommendations that are really going to come from that, and these are kind of recommended thoughts that came from my head. So I am also open to recommendations from the board as a whole. This is not a comprehensive list. Is really focusing on how we can improve trainings and orientations to help you guys feel that you are better ambassadors of this work. And that might also include providing some questions and evaluations or feedback to make sure that you guys feel you are understanding what direction we are going with the organization. Formalizing an equity statement with the board and a few key principles. Looking at how we can identify some regular metrics that we can bring back to the board to demonstrate progress work. Provide routine evaluation of the board, whether it's monthly, quarterly, and we will probably do a more detailed annual evaluation. And right now we are recommending, and what we are looking for in our board format is we will do any of our board retreats in person and do our board meetings virtual, barring COVID, of course, having any kind of changes in the near future. Let me ask, so I'm going to pause for a moment. I know this is my update, but does that sound or resonate well with any board members, or is there any comments board members would like to make from that summary?
John, this is Jesus. That was a great report. Thank you. I wanted to ask you if you would describe a little bit more the work that went into, or the labs around the 211. What was the intended outcome of that? Can you just elaborate a little bit?
I am going to defer to Caroline or Joey. Which one of you would like to take that?
I can take a crack at it and Joey chime in. So the Lab and Learn was supposed to be kind of a two-part training, both information about Washington 211 resources, the call center, and also its website. And then the hands-on kind of skills-based training was using the website to try to find resources for the people that they're helping. And one of the purposes of the training was also to get direct feedback from recovery coaches about what works well and does not work well with the Washington 211 website.
Yeah,
Joey, do you have anything to add?
no, you pretty much covered it. It was just we're trying to have like a one-stop shop for logging in resources and updating it. And 211 has been probably not the best resource website in the past, and we're just trying to make it better. And we're really almost using recovery coaches as, per se, guinea pigs to talk about what resources we use and how to update them on the site, and how to make your own profile on the site so you can log in, have your list of resources, and be quick to give them to recoveries that you're working with in the community.
Well, having a digital resource directory is something that I feel has been evading us for quite a few years. So I'm encouraged to hear some work in this area. I think that that's still a very important need, and I'm glad to hear that some work's going on in that area. Thanks.
Thank you.
There are questions or comments? So just a few quick other updates. In April, the staff is moving to be in office about 40% of the time. We're looking about 2 days a week, having staff members in office. Few staff transitions and updates. I just wanted to announce that this will be David Gaynor's last board meeting. David, can you wave? I know you've all seen him before, but he put in his notice, and his last day is this Friday, April 8th. And I wanted to give David a moment if he wanted to say anything to the board at his last board meeting.
Yes, I'm a Dryden native. Dryden, Wenatchee area has always been my home. It will always be my home. I did not anticipate leaving anywhere near this short amount of time. It's been, I think, 6 months. But after my family sold our orchard in Dryden about 20 years ago, my mom moved to Spokane, my sister and now my nephew moved to Spokane. And I just had this sudden call to get back closer to family, had a potential family health scare that didn't turn out to be what it could have been last Christmas time. So this job opportunity popped up in February. I'll be working with city government in Spokane area, kind of helping build a communication system for them over there. And I just want the board to know, I don't know to what degree you get to interact with this staff, but in the short time that I've interacted with this group, even from the first couple of weeks, I can tell, I can verify to you all that this is one of the most team spirited, team connected staff members I've ever worked with. Everybody is on point, everybody is committed to the mission, and I just wish for everybody to continue the good work, whether it's my current staff that I'm a part of for the next 100 hours, I think, or those of you throughout North Central Washington, still my home area. Continue to do the good work and make a difference, and hope to see some of you on the street someday when I visit Wenatchee.
And it's been great to have David aboard for the last 6 months, and we'll miss you, David. But fully get when you need to transition on or take a next step in life. Few other quick updates. We did hire a director of community data. Her name is Sarah Bates, and she will be starting April 18th, which is sooner than it feels since we just got into April. I will, just as an FYI, my wife is due April 26th, and so I may disappear for a week or so for paternity leave to help take care of our new child when that comes. Hopefully it's April 26th, could be before, could be after. Who knows? I leave that to my wife. And then Joey Hunter, I want to give a big shout out to one of the new Chelan Douglas Board of Health members who got appointed. So Joey, congratulations for getting on the Chelan Douglas Board of Health. He was joined by Dr. Bindu Nayak, Marissa Smith, Alma Chacon, Bill Sullivan, and Joey. So congrats, Joey. And then Molly, if it's
Congratulations, Joey, that's great. Proud of you.
Yeah. And go ahead, John, with the financial update. Thank you. And your guests.
So I'm going to just jump in because I wanted to also introduce Sarah Krosky and Kristen Solberg from Clifton Larson Allen. This has been the team that we have been working with to get set up in our new accounting and financial systems and dealing with all the fun things that we've been gracious to have Chelan Douglas Health District do over the last 5 years, but then we all had to reestablish over the year. And Sarah is going to spend a little time walking through our draft financial statement, which that isn't formalized yet. But I just wanted to welcome Sarah, and I wanted to welcome Kristen. And maybe Sarah and Kristen, you can do a brief introduction of yourselves as well. I'll turn it over to Sarah first. And you're on mute.
It's not a Zoom meeting unless one person does it. So I'm Sarah Krosky, and I'm a controller with CLA. I focus mainly on reporting, so financial statements, annual statements, budget, and metrics. And I just want to take a few minutes to say CLA has its own internal process, regardless of the process that we set up with NCACH. So all financial statements go through a signer review. So a CPA reviews all financial statements and signs off. And then the very first statement, which would be January 2022 for NCACH, goes out for national review. And it's at that national review, once that's signed off, we can finalize financial statements. And then from then on, it's just a CPA review. So the January statements right now, they're just sitting at the national level, getting their reviews. And that's outside of John's review that he's already done and everything. So please let me know if you ever have any questions, comments, or concerns. If I don't know in the moment, I can surely find it and get back to you.
Kristen, do you want to do a quick intro?
Of course. My name is Kristen Solberg. Excuse me. I'm in the biz ops group with Clifton Larson Allen. I've been there for 5 years now, and my focus is in nonprofit. And I apologize, I can't speak today.
And John, would you like me to share the statements or?
Yeah, you can
Okay,
bring
let
up
me
the
bring those
statement.
up on the screen. That way Chris can take a little bit more sips of water. I'm gonna
And as
help you
you're
stall.
as you're sharing in that and getting that up, you know, Sarah would define you as our controller or primary lead on budget related stuff. And then Kristen has been our direct lead and work for any AP, any billing. She's the one who has the lead in our payroll as well. And we utilize a service called Gusto for payroll. And so they work as a very good collaborative team. And they are also all both very responsive anytime I have questions amongst the two of them. And so I always appreciate the speed that they are to get back to anything. And Sarah, do you mind just walking through the format of the budget sheets just to give the board an idea of what they should expect to see each month? And you guys have an ability to ask any questions you have on it as well.
Absolutely. So NCACH reports on the cash basis. So we will always see a statement of where all the cash is at. An upcoming addition that if you can flip to the next page. So this is all the cash that NCACH has. We are going to add a little section come March. You'll see a restricted section. So cash that's restricted that the board has said, hey, we specifically want this much, always 3 months of payroll and operating. So you'll see a less restriction, but you'll always see exactly where the cash position is at. This is tied out to bank statements and then footed in total. So for just the year 2022, you will see CDHD county. We don't pull off anything because there was money still at the county in January. So that won't come off. You'll see that as 0. If ever you saw it not as 0, you should be asking me why. But they'll stay on the statement till the end of 2022. You're on mute, Molly. I missed your question.
No, I was just acknowledging that to myself. Sorry.
Yeah. So we've set the financial statements up as far as every month's P&L, profit and loss, or cash receipts or cash disbursements to show each month, bring it to year to date, show you the year to date budget, and then the change in budget. So how accurate was the budget? What are some areas that we didn't anticipate or we could better anticipate into the future? Along with giving us the ability to talk about any budget amendments that John and I may feel need to come to light. Some of those things would be anything from like an additional contract. Let's say we got another subsequent grant, so we may need to address additional funds in, or maybe they decide to renovate the office and we need to talk about a capital expenditure. So this is just a quick and easy way for the board to see how things are going in actuality every month and then how it compares to the budget annually. This is a disclosure of select information. This changes off and on throughout the months. This is anything that is important to note as far as the omission of any substantial disclosures. So we don't report the pension liability except for the annual statements that are submitted to the state and some of those standard things. So those are omitted except for annually, because those are just reported on the notes to the financial statements for the SAO. This is our significant budget assumptions. This again, when we do and cultivate the budget, we work with a set of matrices and principles that help the budget be accurately forecasted or forecast as best we can based on what we know will happen in payroll, some tax changes. And so this just basically states what we've used to help make that budget happen. And then the last page are some quick metrics that just let people know how the strategic priority is going and how the funding buckets look at a snapshot year to date.
And this is when we approved the budget in December of 2021, it was broken down by strategic priority and funding categories. So each budget was specifically broken down per strategic priority. What we did here is we did just based on strategic priority and just based on funding bucket, predominantly because when we were going through different examples, that was the easiest way to display in a quick snapshot for what we thought would be the easiest way to display for the board in a quick snapshot, how we are doing in comparison to what we approved in December.
So does anyone have any questions on the financial statements? Want to inwardly digest? You can always email John. John can pass it on. You can email me directly.
Can I make one other quick comment, Sarah?
Of course.
If you go back, Caroline, can you go back maybe one more right here? So just one thing to note is when you look at the year-to-date budget, the way that that's calculated right now is that we're taking our year total values and basically dividing it by 12. So what we don't have as a strong budget section that we did last year is we don't have like month to month broken out in exact detail. So you may see at the start of this year that we are pretty under budget, especially under programs. And program is anything that's paid out of the Washington Financial Executor Portal. And so that's any partner payments we have out the door. Now we're developing and we're starting the processes for a lot of those payments. So we'll actually see more of a lump sum coming middle of the year that will catch up to that percentage, but it's going to look for a little bit that we're severely underspent. It's not that we technically, it's not that we are actually underspent. It's just that those payments will probably come out later in the year and we'll catch up later in the year. I don't know if that makes sense. This is an area we'll continue probably to work out how we can refine better in the future.
And John, this is Molly. Will we have the finance reporting done this way at every board meeting going forward? With invited Chris and Sarah. I wasn't sure.
We can pull that offline and maybe talk about that in executive committee.
Yeah.
Talk about with Sarah. We have last year as a practice put in our budget in our consent agenda. Just for the sake of, speed and efficiency at our board meetings, and that there wasn't a feeling that it needed to be presented each month. Maybe for 1 or 2 additional times while we get used to the new budget format, we can look at doing that and then consider moving it into consent agenda in the future.
Yep, that sounds good. Thanks.
Well, thank you guys so much for letting me present the financials. And John, it's back to you.
Awesome. Well, yeah, thank you, Sarah and Kristen, for joining today. We partially just wanted to give them an opportunity to come on, share the updated financials, and input some names with faces as well, so you as board members know who is behind our financial statements. Any final questions?
Okay.
All right,
Thank you,
if
John.
not, I think we are done with that section.
On to the waiver renewal update. Thank you, John.
All right. I'm just going to give me 1 second. So today I just wanted to give an update on the waiver renewal that is coming up. The application is going to be submitted the middle of this year with the start date of January 1 of 2023. Some of the things I just want to note is that, some of these discussions are evolving. What I put in your pack, or what I put in the board packet today, was a slide deck that the Healthcare Authority shared for public review, as well as as a handout that the Healthcare Authority shared as well. Some details have changed a little bit since then, and I'll try to provide some of those nuances. I'm going to go through what I did was infuse a few slides of my own into that slide deck. I'm going to just give you guys a little bit of a summary so you guys have a sense of where the waiver renewal is and where ACHs would be part of that work. I would recommend, I may not be able to answer every question today on it. Some I may ask the Healthcare Authority for more clarification, but we can create a list of questions if I'm unable to provide those answers. I know I saw Kat has joined as well, and I am assuming Kat has been part of those conversations on the MCO side. And so, Kat, you are also welcome to chime in when you feel like it's appropriate to provide your perspective as well. So quickly, today I just want to give you guys and just educate you guys on the conversation, share the timeline, discuss some key aspects of the ACH's role in the waiver renewal, and give an opportunity for feedback. And like I said, a lot of these discussions have occurred at the ACH, 8CA, I'm going to get a lot of acronyms now, MCO level, but this is our opportunity just to give a quick update to you guys. So again, I'm borrowing a lot of this from the slide deck from the Washington State Healthcare Authority, just so that I'm staying consistent with the message that they are sharing today. So the current waiver renewal period ends December 31st, 2022. So as we all know, we had a 5-year waiver that then got extended, and we're in the 1-year extension that ends at the end of this year. And then they're submitting a renewal waiver that would start January 1 of 2023. Right now, the Healthcare Authority is working with partners to get that developed, with the ultimate goal of public comment opening on April 18th. And we were assured again today that they are on track for public comment. And again, all work under the MTP benefits people enrolled in Apple Health. So this is still focused on Apple Health and Medicaid enrollees. Here's kind of a quick snapshot of the timeline that the Healthcare Authority has for the waiver renewal. So again, public comment will go from April 18th to May 18th, with a goal to submit the application July 15th of this year. When some of the official documents do get released, we will share them with the board. And I will again try to provide, probably at the May meeting, another quick highlight of the waiver, just so you guys have a sense of what's going on and you guys feel comfortable submitting any comments. I'm also happy to find time to talk one-on-one with board members if you would like to review and submit comments as a board member or as an organization. You can see up here the 3 key goals of the MTP renewal. So expanding coverage and access to care, ensuring people can get care they need, advance whole person, primary, preventative, and home and community-based care, and accelerating care delivery and payment innovation focused on health-related social needs. So they are, one comment I would say is the original waiver was heavily focused on clinical work, clinical integration, and clinical healthcare improvement. And they have made a shift away from a clinical focus to one that looks at not just clinical, but social health needs and the social determinants of health. What I would call out is those are the overarching goals of the Medicaid transformation project. If you look at the document I submitted for the evolution of Initiative 1, they give 3 specific goals under the ACHs. So ensure equitable access to whole person care, build healthier, equitable communities with communities, and pay for integrated health and equitable value-based care. And for the ACHs, the way that they are visualizing that this will really be achieved is through clinical integration, delivery, and capacity building for health-related social needs and community-based care coordination. So those are really the 3 driving vehicles that we would be actively involved in the waiver renewal. And I'm going to cover those in a little bit more detail as we go through. And anyone feel free as we go through this to ask questions or add any additional comments. So with the 3 goals that are in the waiver renewal, goal 1 is focused on expanding coverage and access to care, ensuring people can get the care they need. So under this goal, you can see in those 4 bullets some of the key focuses of the waiver renewal from the Healthcare Authority. I'm going to let you guys read those. What I share really in goal 1 and goal 2 just shows that the waiver renewal is, a larger initiative than just what the accountable communities of health are doing, but it really involves a number of components around renewal, Healthcare Authority work. And so that's, when I share the comment, there will be some key things we'll be able to provide clarity on that we're specifically directly involved in. There may be other components of the waiver renewal that impacts your organization that we may not have as many specific details on. Goal number 2, you can see advancing whole person, primary, preventative, and home and community-based care. A key example of goal number 2 that's going to be continued is the continuation of long-term services and supports, specifically around the MAC to SOLA program, which was, if I may get this correct in my head, initiative number 2 of the original waiver renewal, or the original waiver. One component of this that ACHs will be involved in is continued progress towards integrated physical and behavioral health. And so currently, the accountable communities of health are working in conjunction with the Healthcare Authority and the managed care organizations to develop and roll out a new integrated care assessment that will be replacing what originally was the MEHAF. And so they plan to start their first cohort of primary care and behavioral health partners completing that assessment this summer, and then proceeding through a few cohorts, another cohort, I believe, in the fall, and then really expanding that assessment throughout all providers across the state of Washington over the course of the year. So we will be, as ACHs, we have been directly involved in helping put the assessment together and working with that work group to get the information out and develop the plans for analysis of the information, as well as providing technical assistance after the providers have completed the assessment. It hasn't been determined yet at this point who will be providing the technical assistance after the assessment is done, but the work group is working out those details. Right now, Healthier Here, which is the Accountable Community of Health in King County, has the contract to help with the implementation of the assessment and collection of information and data. And they're also looking at a organization who would do some of that analysis. So more details to come, but that's just an example of the waiver renewal, how we're directly involved in that work. Goal number 3 is really one that has predominant focus of the accountable communities of health. And so really accelerating care delivery and payment innovation focused on health-related social needs. And Kat, I know you're involved in these conversations too. So again, I encourage you, if I am misquoting anything or if I get something that doesn't sound right in your head, feel free to jump in and provide extra details. So one example of a program that was in the original waiver that is going to be continuing in the renewal is the foundational community supports. And so this was really supportive housing and supportive employment services for those who are in need and who qualified for those services. And currently the third-party administrator for those services are AmeriGroup. And so from my understanding, that program will be in the waiver renewal for next year in the same format as it was in the initial waiver. So they don't have any planned changes to it, but they are still looking at continuing that work for the next 5 years. And then again, I tried to bold anywhere where our name might stand out or where we might be involved in that work. But ACH, Accountable Communities of Health, Managed Care Organizations, tribes, and other partners will take on new projects to build health supports beyond clinical care. So an example of that is being discussed and worked out is health equity and community capacity building funding that at this current juncture would go through Accountable Communities of Health to support building capacity for anything related to health equity, community-based care coordination, or other social needs in our community. Again, I say the details on that funding is being worked out because really the title is the most details we've received in that aspect. What we do know is the priority will be around health equity. As well, the renewal would allow the state to pay for certain services that address unmet needs beyond clinical care. I'm going to say this slide is actually one of those slides that is continually evolving in the moment. So the original assumption, and I shared this with the executive committee at our last executive committee meeting, is that they'd have 2 paths of services to complete this. One is called in lieu of services, which you can see ILOSs are alternatives to clinical care proven to be medically appropriate and cost effective that run through the managed care organizations and would be considered part of what the managed care organizations does. Kat, I would probably defer to you to explain that in greater detail than what I could explain because you would be more knowledgeable in lieu of services.
I'll just share a little bit more detail, John, just to clarify sort of what is being proposed to change. Currently, in lieu of services is a component within our managed care contract at this time. The challenge with it at this point in time is it's one service, one individual. And there's a lot of administrative hoops that we have to go through with healthcare authority to have something be approved. So I think there's some subsequent slides that start to speak to the healthcare authority is aiming to have a defined list of services that would be eligible for in lieu of services, and that there would be a population in aggregate that would be eligible for those services. So that's sort of really the big change that we're seeing from a managed care perspective. At this point, there's a number of other changes that are coming forward, but from an in lieu of services perspective, just so folks are aware, that currently was within our contract. It's a pretty sort of limited ability and application right now. And so seeing some of the proposed changes as hopefully creating some administrative simplification and broader eligibility and application of those services, across the state.
So another term you'll hear and another aspect that they're working on under the same concept is health-related services. And so whereas in lieu of services have always traditionally run through the managed care organizations, and Kat, help me understand this, they're part of your administrative fee. So they're not part of, they wouldn't be part of the, they would not be part of the, I can't remember the term that I'm thinking of. They wouldn't be part of the balance for the waiver renewal.
That's our understanding at this point in time. And again, that's where the terminology comes from, and that it's in lieu of another service. So that ability to pay for a certain service that is in lieu of something else. And we can talk about some of the details that we have questions about related to some of the components that are being proposed are being modeled after California. And one of the elements that was approved for California was there was the opportunity to show future savings of the service versus just the specific service that it is in lieu of. So I know that it's a nuanced and slightly complicated topic, but that's our understanding, is that the in lieu of services would currently that the funding components would not be within the waiver, but that the specific services that are sort of outside what is currently able to be billed for would be paid for through what's coming forward in the renewal.
And the term I was looking for with budget neutrality, I could not figure out at that current moment, but each waiver is required to be budget neutral in the way that they do their calculations, and iOS does not fall within that budget neutrality, correct, Kat? Yep.
Oh, I understand that at this point in time, yes.
So the Healthcare Authority has also been looking at doing what's called health-related services. And so this has some similarities in lieu of services in that it's looking at paying for health-related needs, such as housing, nutrition, and transportation. So not those traditional medical visits and reimbursements. And that the Healthcare Authority is still working on adopting and developing that list. What I would say is, in the evolution of the discussion, those two topics are more coming in alignment in the waiver renewal, and they would be supported and managed through an MCO structure in the future. But in some of the public documents out there, what you will see is those two terms probably still out there in discussion. It's probably something we could spend focused time on at another board meeting in much greater detail.
John, there was a conversation going on in the chat with Penny. I wasn't sure if you were seeing that.
I am not. Penny, you said, can you just speak to your chats, Penny? I know you have a few in there.
Oh, I was just adding that you were talking earlier about the Medicaid piece. The Behavioral Health and Reentry Committee that I am on was looking at renewing Medicaid. HCA has a work group working on it now. They were looking to keep Medicaid in place 30 days into the juvenile justice, but also to reinstate that Medicaid 30 days prior to discharge. I would like it to be 90 days, because then we could do like a DBT with the parents and the kids and do a trauma, so that, you know, they're introducing them in with more wraparound services. But right now they're looking at 30 days. So that Medicaid would be reinstated. And then when you were talking about in lieu of services, you know, like right now, Medicaid isn't paying for, you know, adaptation for even your bathroom. You know, you can't get adaptation bathroom service, bathroom pieces, you know, grab bars, toilet rises, different things for your tubs. But if you're doing in lieu of services, you can get those things, which of course could save you from having like a bath assistant. So I was just saying that that's, you know, like an easy show of how in lieu of services could work, much simpler than like the carpet removal, which would be, more of like a mobility issue. But right now we don't even have bathroom adaptation devices that are covered, which of course could save you from, maybe having to have a bath assistant come into the home, which is a great difference in price and savings. So that was just an example.
And some of those adaptive devices have come up in conversation. So I would encourage you to bring that up, especially even during the public comment period, to submit ideas and recommendations like that. Because it's not, I think, my understanding with the healthcare authority is they're still trying to get a good understanding of what those kind of services and what those waiver flexibilities would be. And so they would love to hear what are some of the key flexibilities that would make a huge difference.
If I could interject one more time, the other thing was you were talking about travel, and I've been talking to special mobilities up in Spokane. And, right now, the way that their program works, they are in the parameters that it has to be your closest provider, which they have, of course, agreed that being in a rural area, which we are Central Washington, that does not give us the best providers always and what we need. So we are in a disadvantage when it comes to most of the programs that are available, because special mobilities is saying you have to see your closest provider, and that's the parameters of what their funding is under, right? But we are in a rural area. So often when you have a very clinical or a very acerbated situation like my health issues, you're not covered. So if you have to travel to more specialized providers, that isn't available to you. And you're giving an example of why we need that, because we're in a rural area, right? Central Washington. So.
Sure. Thank you, Penny, for those comments. So here, I'm just going to share has been a few target populations and those that have been talked about under the health-related services. So I use this as an example again. What they're looking at is, and I don't know if this will change, but they'll look at a list of specific services and they would probably look at identifying some key target populations to focus those services on. And so examples of target populations that have come up in conversations, you can see as individuals transitioning out of the criminal justice system or involved in the criminal justice system, pregnant individuals and families with infants, youth experiencing unmet social needs, and individuals and family members impacted by public emergencies and adverse events. Noting that some of these aspects would need to get defined in further detail. And so I would say at the current juncture, so looking at the renewal submission, they want to get a good sense of some of the high level things we're going to be focusing on. And then knowing that over the course of this year, we're going to be working out some of the details. Another large aspect of the waiver renewal is going to be a concept around community-based care coordination and the idea and the aspect around a community hub. So what the renewal is looking at is having each ACH oversee a regional community hub to deliver community-based care coordination across the entire state, not one ACH across the entire state. When I just read that, that's what I got a sense, but each ACH would be looking at how we develop a community hub in our region to support care coordination across our region. And then, ideally how much it can complement each other across the state. Some of the definitions and some of the concepts that have been brought up in this community hub concept is community hubs would serve as a regional networks to identify and engage people who have health and social needs and help connect them to community organizations and resources. So you can see under some of those key bullets, some aspects of a community hub that would be implemented. So community hubs would leverage and optimize existing community-based care coordination resources, as well as make the investments. They will increase community health workers and peer workforce to support community-based care coordination and equity, work with existing healthcare coordination entities to support continuity between clinical and social services. And there would be multiple points of entry to supported by community information exchange technology and further development of workforce capacity. So really a community hub in essence is really looking at how we are coordinating care coordination across the region and how we're creating a system or structure to support that coordination. One thing I would say, and has come up in state discussions, is we're not assuming that the ACH itself in this current juncture would become a hub like the Pathways Hub. So I know in the original waiver, Project 2B, community-based care coordination had a focus on the Pathways Hub model, and that our region had implemented the Pathways Hub model and decided to move away from that. In our discussions with the state around the waiver renewal, we are not assuming that we are going directly back into a Pathways Hub model concept. I kind of just want to emphasize that because that's been a focus and a discussion on our side with the state when we've been looking at it for a region. Teresa, you have your hands up.
Yeah, thank you, John. So yeah, you were kind of starting to answer my question because we already have care coordination up and functional as it relates to our COVID response. It's actually a pretty exciting opportunity that many of us have already engaged in. And there has been quite a bit of conversation across the state because the ACH involvement is so different across the whole spectrum. And it's a tad bit frustrating that they're trying to do a one size fits all and that they haven't been engaging local public health in these conversations. So I appreciate you moving this forward, and please let me know what I can do to help assist so that we're not duplicating services or potentially hurting our local entities by creating a separate system.
Yeah, I would say each region does it a little bit differently. There are some ACHs who are more heavily involved in care coordination and have more of a traditional hub component associated with their organization. And so they may take on more of that role in their region just because of the infrastructure that was built in that region. Excuse me. That is something we had chose not to do in the past. And so, sorry, I would, as you read through these components, the thing that I would really clearly articulate is this may flow through as a waiver renewal work through the ACHs, but we would, as a region, would be looking at how we best collaborate on this work as a region. So none of this assumes that we are going to be a hub, or we're going to take a lead, or we're going to start asking others to give up authority or work that they're doing. And Caroline, I see you unmuted, so.
Yeah, John, correct me if I'm wrong, but I think one of the things that the ACH executive directors have pushed back on the state on is to ensure that the healthcare authority is coordinating with the Department of Health so that those two systems don't inadvertently create duplication or fragmentation that ends up making it really difficult for communities. So I know that's a work in progress.
Yeah, you are correct. I think in general, there's a lot of hub-like entities out there doing different services. And so that, again, the idea is not to create one more. The idea is to figure out how we support that work to be more collaborative. And so I'm going to show, make sure I'm doing well time. Here's some hub functions that have been identified through the healthcare authority. And so again, some of these may sound a little more like traditional hub roles, but this is where I say, what kind of gets defined through the waiver will also be brought down to us, and we'll figure out how we best coordinate that across the state. So identify and engage patients who likely have multiple health and social needs. Screening. And I know, Teresa, you've even brought up the comment too of, when we were talking about COVID Care Connect, that is it makes sense to have, like, send referrals up to an entity when you could just send them directly to the people you're working with. And so again, when you see screening patients for SDOH needs to determine the appropriate organizations with resources and knowledge, I would caution to say that that's not the mechanism or model we are actually looking at going. We would look more collaborative across partners. And establish and ensure network of community organizations, and really ensuring that we are connecting patients with those community organizations that help address SDOH needs. Few other hub functions continued. So community organization network provider payment, which I actually think this one is getting adjusted a little bit. Follow up to ensure patients are connected and facilitated, and facilitate completion of interventions or activities. The track outcomes may be more of a traditional hub function, and that's where I think that would be done in conjunction with community partners, and ensure accountability. Again, ideally, I would go back to this slide that ultimately explains how we visualize community hubs in the region. But I did want to share those other two slides because those are slides that the Healthcare Authority created. And you will see some of those talking points, but it really comes down to this is where our focus is as ACH is. So the questions that the Healthcare Authority is looking at when you're looking at this renewal package, is there anything that excites you about it? Is there anything that concerns you? Is there anything you want to make sure that we know? What is working well now and what should be preserved? And then any other feedback. So Teresa, for those of you who have been active in hub work, especially through COVID Care Connect, I would love for you to continue to look through this information, look through these kind of documents, and provide the feedback you think is important for us to report up to the state to make sure that we're staying in alignment with the way that our region's thinking about community hubs. For providers who are going through clinical integration work, I would also encourage the same, especially in the things that your organizations are keenly focused on, to make sure that we are getting a sense of what you guys feel, what concerns you have, and what we can report up to the state. Other than that, is there any questions? I know, Penny, you asked about telehealth. And I don't believe, actually, now that I think of it, that I've seen anything specifically outlined in the waiver around telehealth.
My biggest concern with telehealth is I just wish that the reimbursement would be fair. I think when we're using it, what's happening is we're having a higher rate of, okay, you guys know I can't brain, right? That I'm having like cognitive issues, like for real. But it's a higher rate of making sure that appointments are being made, right? So whatever that's called. So patients are actually having their appointments. So when they're not missing their appointments, then we're not having like those major incidents, right? If you're not having the major incidents, you're not using that higher level of care. So reimbursement for telehealth, say it's a mental health issue. So if with a mental health issue, if you're usually missing 70% of your appointments, but with telehealth, you're actually getting to 80% of your appointments. So you're not having this major break where you're needing to be put into inpatient care or having these ITAs at the hospital, you're actually saving money. So how can that reimbursement be fair enough? Because you're actually saving money. It's kind of like putting that adaptive equipment into the bathroom. If that adaptive equipment's in the bathroom, grandma's not falling and breaking her hip, and you don't have her in the hospital doing like a hip surgery. So where's this preventative, the preventative care? Because with telehealth, that if you're not getting the travel that you need from SMS, so you can't travel, or maybe you just don't feel well enough to get in there, or whatever is going on in your household, or you don't have the childcare, that telehealth is getting the actual the appointments are happening. So when those appointments are happening and we're saving ourselves from these high-end costs, what can we do to make sure that that's being compensated? Because it's saving you money. I'm telling you, I'm using it better. I'm telling you, it's saving you money. So how do we reimburse the providers for that? I know that there was something that was going to be a billing go through for telephone calls. They did a new code for that, and there was supposed to be a small increase for it, but how can we support that? And also, how do we support those that are using it, to make sure that they have the equipment to be able to be having these telehealth appointments? That's another part of it.
And I may defer, I don't know, Kat, do you know on the MCO level, at the state level, if there's anything going on around telehealth, or you as yourself, Senator Warnick? I don't know if that topic has come up in the legislature as well.
It has, this is Judy. It has, but I couldn't speak with authority on any changes or any modifications to it. I could look into it.
I know
But-
there was a billing code given for telephone calls. Do you remember that, Senator Warnick?
No,
They did
we
give a
don't,
billing code
we
so
don't,
that you could bill out.
we don't necessarily get into the billing codes, but there may have been some authorization, but I could certainly look into it.
And maybe we can dig into that, and Penny, we can get back to you with any information.
I think there was a 7% increase. That's, for some reason, that pops up in my head, but just that support there. And how do we support the patient so that they can have those appointments? Because especially with like a mental health patient, if they're getting to 80% of their appointments because they're using telehealth, you're going to save money. They're not going to be in your ERs. They're not going to be having major events. It's going to save you money for sure.
So I'm going to transition on. Caroline put a comment in the chat to recognize when we use the word hub. Right now, that can be a confusing term because depending on who you talk to, it can mean a number of things. And I want to acknowledge that because that gets talked about even at the ACH and state level. And that is true. Better understanding what it means when we use the word hub will be very beneficial as we go through these conversations, just to ensure that we are clear on what we are saying when we use that term. Any other comments or questions on what you saw on the waiver renewal? Jesus, I see you turned your screen on. You look like you're trying to say something.
John, thank you. I just wanted to maybe connect the dots on some things that are happening that might be relevant. So I know that CHPW, or is it CHNW, they were the recipients of the Department of Commerce monies, multi-state, multi-year funding to support essentially capacity building in the consumers and on the use of telehealth modalities. So it'd be interesting to know how their work can dovetail with our efforts so that we can find complementary roles and avoid duplication of investments. So that's one thought on that side of things. The other social determinant of health that's getting a lot of attention is housing. And because I serve on the board for the North Central, the Community Foundation of North Central Washington, I know that their service area is Chelan, Douglas, and Okanagan. They don't serve Grant, but I want you to know that there is an initiative being developed around investing foundation dollars in essentially housing ventures, I guess you might call it. So in the same way the foundation invests in nonprofits to address social needs, for example, they're looking at an innovative way of investing dollars to promote more housing stock. So it would be another opportunity for perhaps to look at that initiative and see how North Central ACH might collaborate or support, because if and when that happens, I mean, those are the biggest root issues of our problems. And I mean, there's just, we got people that are need housing, but there's just no housing stock, at least in North Central Washington. So it's another initiative that it's beginning to take form here in North Central Washington that we should be connecting with, I think. I'll be happy to connect you to those folks.
That'd be perfect.
And in terms of accessing telehealth by the consumer, the North Central Regional Library System could be a partner because they have libraries across the region. They could potentially be natural hubs that we could plug into so that folks can have a local place, especially now that COVID allows it. We could, that could be another partner to look at in terms of creating access points for consumers.
And I think we will cover a little bit of that in Wendy's presentation. She just said to hold those thoughts, Jesus. She has more information. So you're stealing her thunder is what she's trying to tell you.
Oh, sorry about that. I should have waited.
Kat, I saw you were unmuting. Did you have any comments?
Oh, just that, John, I think you did a great job in your overview of a pretty complex topic that we're all trying to dig into a little bit more so to, better understand collectively across the different stakeholders. I think as public comment comes forward, would just sort of encourage folks as we think about the list of services that's noted for the umbrella of the health-related services that would be funded through in lieu of services. And just thinking through things that you all have tested and tried, things that you all see within your community that you want to see elevated that might not be captured there, would just really encourage this group to take a look at that and maybe see where there are opportunities to elevate that. One thing I know that has come forward in this region, as well as within the Greater Columbia region, has been community paramedicine. And that's an area that right now, when we look at the list, I don't see it. I'm not, maybe there's sort of ways in which they're thinking about how it would come forward. But just as we think about sort of things that have been tested and invested in the first 5 years of the waiver, how are we continuing to promote that through the renewal process? And so just would elevate that lens that people could take to the work as the public comment comes forward.
All right. Well, thank you all. I'll turn it over to Molly. As more information comes out, we'll share. Kat was nicer than really the truth is. I wasn't really that articulate in the presentation, but I am continuing to get better at it. So feel free to ask questions and please, when it comes out, comment. So Molly, I will turn it over to you.
All right. Now the agenda at this time does show that we would have a short break. So I'm sort of like deferring as to Wendy. If we were to start back at 2:30, that would work for you. Okay, we're gonna try that. I just want to give everyone a chance to get some water and then come back and we'll start right at 2:30 for the telehealth. Very important. Thank you. All right, welcome back, everyone. I did also want to add that you do have the PowerPoint slides that John presented on pages 8 through 20 of your board packet so that you can review that at your leisure. This time, we're going to bring up Wendy on the Telehealth Proposal, Telehealth Capital Investment Fund. Wendy?
Thank you, Molly. Let me get my screen back in order. There we go. All right, good afternoon. I am looking forward to this discussion. This is a culmination of almost 2 years of discussion and assessment and more discussion. So I'm looking forward to finally doing more and getting some implementation done. So let's get started with a little background. Because we have several new board members. I'm not going to read everything on these slides, but I did want to include all the information because there's several new board members who haven't been here since the very beginning, and I wanted to make sure that they were caught up. So when COVID began and our clinical organizations were pivoting towards telehealth, some more than others, I was asked by the executive committee to assess the needs of the organizations. And this was done, and then information was brought back to the executive and then to the full board, which led to several discussions over several board meetings. Some great discussions, some great will, but it was ultimately decided that we should conduct a community and clinical assessment to better inform the board and to help guide the staff in implementing next steps. So in February and March, you heard from Ingenuum and WSU on their findings. So if you weren't at either of those board member meetings, I hope you were able to watch those presentations so that you have that background information that leads. I will go over a little bit today, but there's a lot more that was given in those presentations. So today we'll review our strategic priorities of our organization that the board approved last year. And then we'll talk about the assessment findings from both Ingenuum and WSU. And then we'll talk about some next steps of how we can do some implementation. So first up, strategic priorities. You've seen this graphic several times, so I'm not going to spend a whole lot of time on it. These are the 5 staff strategic goals that were approved last year. And when thinking about telehealth and our implementation, this will directly impact 3 of these goals. Telehealth plays a significant role in coordinating a whole system response to whole person health needs and improving the health outcomes for people struggling with behavioral health issues by breaking down the barriers that patients face. By implementing these strategies to improve telehealth in our communities, we'll be helping our partners to respond to demand for services. So this is directly related to what was approved last year. Specifically on the help partners respond to demand for services by increasing capacity building supports for partner organizations. Telehealth was included in that, but it was unfunded. It was unfunded because we weren't sure exactly what the assessments would say. And so we wanted to make sure that we had full information before we brought to the board an actual budgetary amount. So some of the next steps, recommendations and next steps. So we'll get into the meat of it. WSU presented on the community assessment. There were 4 different areas. First one is broadband access, and I'll speak to this a little bit. We understand that there continues to be broadband issues. Not only is it that broadband's not available in some areas, there's also issues with connectivity due to cost. For example, you may have fiber in your area, but the cost to wire your house or pay the monthly fee may be unattainable, and therefore you don't have broadband accessibility in your home. I do know that Okanagan County currently has a broadband action team that's working on improving access in their region, and I'm not sure about their PUD, although I do know PUD is on that broadband action team in Okanagan. And then Grant County and Chelan County PUDs are in the process of providing access to fiber to their whole county. I'm more aware of it in Grant County and less aware of it in Chelan County. But I do also know that there's some satellite options. Again, there's the cost of broadband that inhibits many from signing up. The second one is technology challenges that they brought up. So there's some potential opportunities that I'll talk about a little bit later as it pertains to technology. The next 2 are telehealth preferences and community education and building trust. There's definitely a preference by individuals on how they access or if they're able to access, and building trust is very important with these individuals to access telehealth. So some of the recommendations that come out of WSU's assessment, and these 2 are definitely potential opportunities that we can tap into in our implementation. Ingenuum completed their assessments and showed the board the diverse maturity levels across the continuum. And based on that, they developed several opportunities that would help move these organizations along the continuum, including those under shared support services and shared support resources and individual services. So there's a lot of different opportunities, and we'll go into it a little bit. It doesn't mean that every organization needs to tap into all of these. Actually, they're not all applicable to every organization, and you may tap into one resource, which we'll cover another resource that's also listed. So it's built to be very customizable based on the organization's, not only their needs, but they're also what are they able to handle, because they may have greater needs, but due to staffing and capacity within their own organizations, they may not be able to do everything. So really personalizing that for each organization. So we're moving fast because I really want to get to the discussion. So there's a lot of opportunities to partner within the community, including the library system. Thanks for queuing me up. Jesus, I've actually spoken with the library. Latest conversation happened on Friday. As soon as we had some finality within how we want to move forward as an ACH, they are ready to meet and how we can partner together. They actually just received a $10.5 million, I forget what it's called, I have it later on in the presentation, but it's to reimagine their libraries of what their libraries could be like. And so they're looking at telehealth and health related services within the library and how to assist their patrons. And if you talk about the trust, which is something that WSU mentioned, it's definitely an area where there is a lot of trust with the library system. There's also opportunities in the community centers, such as the Pateras, the Brewster Community Resource Center that WSU reported on. Potentially the educational service districts. I know we have one organization that's looking at school-based telehealth. There's also a digital navigator program, and Jesus, I think this is the one you were referring to with I think it was CHRN. I'm a little fuzzy on that acronym as well, who actually did receive the grant. The North Central Washington Tech Alliance out of Wenatchee that covers our region applied for the grant. They were actually looking to cover 6 counties, but they did not get that grant. But the one thing that did come out of this Digital Navigator program was the amount of interest, the amount of partners that signed up to say, yes, we support this, and the desire within the community. So to have such a program. So there's definitely some opportunities to look at. So these are like the community opportunities as we look forward to what is the potential. The next one is clinical. The idea would be to contract with Ingenuum, and it's not so much as that I think it's just a continuous, because Ingenuum did the maturity, they understand where each organization is along their maturity, what their needs are, and help guide organizations based on where their organizations want to go based on their own strategic plans. As I mentioned before, there's a lot of overlap in services. We did send out a survey to the different organizations, and I believe we received 6 replies out of the 10 to determine not only their level of interest, but when they would like to get this started. So one of the things I can show, and I said that not all organizations would need all services. An example would be, let me see where I had it. An image for organization may first want to develop a telehealth strategy as a starting point. They don't have a telehealth coordinator or a robust system, so there would be no reason that they would need coordinator services, or there's nothing there to even optimize, but they may want to train their clinicians on website manners and instituted tech check programs. So that would be one example. And on the other end of the spectrum, an organization would go with an accelerated collaborative telehealth optimization. This would be someone who's already doing telehealth in a robust way. And they would most likely not need the toolkit or the website manners or tech check or telehealth strategy or marketing. Those are all basically covered in that accelerated telehealth optimization strategy and support. So there's definitely, yes?
Sorry, it's Caroline. I know you told me to keep an eye out for chats and who's unmuting because you're sharing your screen and you can't see that. And I noticed that Jesus, you came on video and unmuted. Did you?
Do you have a question?
Oh, no, No, go ahead. Please continue on.
Okay. Feel free to unmute and just interrupt me as I go. I'm just kind of clicking through there, and there'll be ample time for opportunities, but I'm happy to stop if you have any questions as we move through this.
And I'll keep an eye out on the chat for you, Wendy.
Thanks, Caroline. I appreciate that. So the idea would be to assist clinical organizations on building out their telehealth program and tailoring it to each organization, as well as providing funding for clinical organizations or partial funding to support the upgrade of their own telehealth equipment and software infrastructure to support the offering of telehealth. And when I say software infrastructure, that means the hardware, software, networking components, operating system, data storage, all that goes. And I'm not talking about new EHR. I'm talking about those directly to their building out their network to support telehealth in general. So what I proposed in the board decision form that you saw was $2 million. I did fail to put the timing because I wasn't exactly sure. I was still working with Ingenuum and WSU on this. But we looked at it, and realistically speaking, we thought it would be over 2.5 years. It's not something that would be done by the end of the year. It took us a year to do just the assessments. But the breakdown would be $500,000 for the community partners and $1.5 million for the clinical organizations. I did meet with both Ingenuum and WSU, and that was the consensus with both of them after last month's board meeting. They both said an 80-20 split, which is 400,000 based on the assessments. I presented a little bit different because I felt that additional 100,000 sent out to the community could go a really long way. For the clinical organizations, based on the assessment and conversations and recognizing that both community and clinical assessment said that clinical organizations need to build out their telehealth in order for the community to even access it, is why we put that a little bit much higher at 1.5 than the community. But if you look at it, that's averaging about $75,000 an organization. That means we have about 19 clinical, that's primary care and behavioral health organizations within our region. So averaging, however, we want to ensure there's flexibility to be able to fund organizations to the point that will move them along that maturity or continuum. So I say average because some may need 20,000 to 40,000, while others may need 80 to 100,000, just kind of where they're at. And that is something that funding formulas that the staff can work through once we understand the direction of the board. And so some things to consider is not all clinical organizations will participate, at least in the beginning. As always, there's early adopters. And I do know that we have 6 of the 10 who've responded to the survey and are eager to get started in some way or another. The other, I have heard from 1 that's not interested at this time. And then there's other organizations who didn't do the maturity assessment who may be interested in this, but maybe in a wait and see. COVID still has them hung up and they've just now kind of digging themselves out of it and may want to jump on board as they see other success in other organizations. The idea is that we as an organization have plans in place that we can be shovel ready and competitive as grants are available for this telehealth type work. And that we're working with others who are funded like that CHRN organization that received that Digital Navigator program, and what are they doing in our region? And how can we work with them to leverage resources and potentially weave the funding together to build out our systems in North Central Washington? So what else did I put up here? There's several that have expressed interest in participation. We just need to outline the specifics. I spoke to you about library system as one of them. There are some telehealth grants that we could potentially apply for. Again, they're not guaranteed, but we can apply. And John could speak more to this, but I learned that telehealth is a part of the chart model if that model is adopted in our region. So I'm going to stop there and see if there's any questions or conversation.
Wendy, when it comes to engaging the consumer in telehealth, there is a lot of need to help people just use the technology in general. Then you also have the language needs that become a part of that. And so that's another layer of training. We're struggling personally at Family Health Centers with that because we're trying to train up our community health workers or MAs to do to pass a test, a competency test, where they are able to translate with a degree of competence that can be measured. It's not to the complexity of getting a what's that state medical translation certificate. It's not that complex because that frankly intimidates a lot of people and not very many people go that far. So we found essentially an online test that just allows people to demonstrate some competency of terminology that's commonly used in healthcare. So the language needs in our region is very much part of the telehealth picture that we need to consider, in addition to also helping the consumer with the use of technology. So that's why I think that looking at the digital navigator project and seeing where we can engage them and then complement that work with the work, whatever work we decide to do, would be wise.
I agree with you. The digital navigator program that the North Central Washington Tech Alliance proposed was partnering with individual or organizations within each county, and there were 6 counties. And so we'll take Okanagan Economic Alliance, I believe it's called. I may have the name a little bit wrong. But they have digital navigators, but they were going to add a telehealth component into it. And so how can clinical organizations share a common resource, and those clinical navigators be trained on the different interfaces of the different EHRs and how to access telehealth the way each organization would like. So it's a shared resource. They would contact patients ahead of time to make sure they understand how to log in, when to log in, and what are the specifics for each organization. So that was the model that they had, and it's definitely a model that's been Christian from Ingenuum calls them tech checks, very similar ideas, just checking in with that patient prior to the appointment to ensure they understand the technology needs and how to access their appointment prior to actually logging in for their appointment. So definitely on the radar. Any other questions, comments?
I guess I would just add that it's important to recognize that I think most health systems have adopted some type of telehealth component or module into their electronic health record. So we're going to have a variety of those to work that we'll have to work with, or consumers will have to learn to work with. So understanding that, I think it's going to be important because we have patients that are also seeking specialty care at Confluence, or they go to the hospital, and everybody's using a different EHR, therefore a different interface for virtual care. And a lot of these things are baked into the EHR, so it's not like we can create something that is common to all.
Right. Right.
Wendy, this is Kat. I just had 2 questions. One was related to sort of if there's any more detail related to how telehealth is going to be part of the chart model. That was the first question. And then the second question is sort of the balancing of the proposed sort of investment and thinking about the community investment needs sort of along with the clinical investment needs, and was just sort of wondering sort of how you all came to that, and was some of that informed by some of the other community resources that are out there that could complement the investment in the community partners. I just wanted to get a little bit more insight into that.
So I'll let John speak to the chart, but let me answer your second question first. And so there was some consideration in it. The idea is this year is our bridge year of moving away from clinical and more into our community. And we understand that in order to be successful in building out telehealth, we need to get our clinical providers to a point that they can optimally provide telehealth service. It's beyond just having a Zoom license and computer, and every organization can tell you that. There's more to it. There's workflows, there's training up of staff. There's just a lot to it, more so than in the community. So these are more like, I could say probably more like one-time investments or short-term investments of getting, bringing up the maturity level of each clinical organization, whereas the long-term game is really focused on the community. So once we get that clinical organizations to where they need to be able to provide services, ultimately we can really focus on the community. So we'll see that dive in funding for clinical organizations and hopefully increase in funding for community organizations and receiving. There's just not, when the budgets came out, speaking with WSU, it just doesn't cost us much to bring a community organization along to provide space for an individual to do telehealth services compared to the cost that it takes to bring a clinic to optimize telehealth within a clinical setting. And so that's kind of where we were looking at it. And we didn't want to give pennies when it's going to take more dollars. And so we wanted to make sure that we were funding it in a way that would really benefit our community. Does that make sense?
Yeah, thank you.
Okay. John, do you want to speak to the chart model?
Yeah, so chart has a few different components associated with it. What I said earlier on in the executive director update is, there's a large focus around the alternative payment model for hospitals. But on top of that, there's another component that needs to be done as part of chart is there's a needs assessment that the healthcare authority did, and then there's a community transformation plan that also needs to be adopted with 3 key strategic priorities. And one of those priorities, it has to cover, or has to include a component of telehealth. So I dumped in the chat, Kat, what a draft strategic priority number 3 is, which is improved care coordination for high cost, high need patients with chronic comorbidities through telehealth appointments, including voice and video calls and care management interventions. So the community transformation plan is going to get adopted as part of chart, and some of the focus is going to be around those strategic priorities. So again, some of it is contingent on the hospitals signing up for the initiative once the alternative payment model comes out, and ensure that it helps them be financially sustainable. But part of that focus will be on telehealth and how to utilize telehealth to improve patient care. And really, a large component of chart is, if we were to be honest, focused on controlling costs in a hospital setting as well. So how can some of those levers be utilized to help support that?
Thanks.
Wendy, another comment on telehealth and COVID. Growers have been handed some very specific expectations for protecting ag workers from COVID. So they're doing screening, testing, but once somebody tests positive, we've had one large grower that reached out to us, and so that we could be the provider of providing the first determine what the care that's needed once somebody tests positive, and then ensuring what follow-up care those individuals might need. So I guess what I'm thinking is that growers is another area, another sector where there may be an opportunity to see if telehealth can telehealth barriers may need to be mitigated in terms of, and this particular growers is reaching out to us is dealing with guest workers that are arriving in large numbers, and so that's something that is kind of urgent and coming just around the corner, and it's of course around the entire region.
I appreciate that, Jesus, and I will definitely put that on the list. The idea would be, we'll use your organization. You guys are optimized and using telehealth very well. So let's look at the farming, that sector around your organization. I wouldn't want to do it in the whole region because I wouldn't want to engage farms in an area where their health system isn't as optimized in telehealth until we get that optimization, because then it's just, it's a fail, right? Everyone's going to be frustrated and no one's going to want to use it. And so the idea is to bring the clinical up and then start to engage those different sectors. Because you're right, there's the farming, there's PUDs, there's schools. It's the same with the school-based health. For the organizations who are trying to do school-based telehealth, let's engage those schools in that area, not the entire region. So it's definitely a rollout. And it's going to depend on where each clinical organization is on how we engage the different sectors within their area. So thank you for pointing out the farmers, because there is definitely a need with the H2A workers. Any other questions, comments?
Wendy, this is Dell. The other comment I had is that telehealth is also vital, especially for specialty services where there's a workforce shortage. Because I'm more speaking to psychiatry, where there's a shortage of psychiatrists or psych ARMPs across our region, as well as statewide, nationally. But a lot of the telehealth organizations have snatched some of these individuals up and are contracting them out to health clinics and to behavioral health facilities. So we entered into a contract with Iris Telehealth. So beginning in August, we'll have a full-time medication management provider available to our county on a full-time basis, which will be a huge help to our county. And then the client population will be able to access them by coming into the office or by their phone at home. But our intent is to have them accessible no matter where anyone lives throughout the county.
That's great, Dell. Rosalinda, you have your hand raised.
Hi, thank you. So we don't have any cost estimates for what we're planning to spend in these areas. Was my first question. The other one is, John, are these budgeted monies that we set aside for use this year, or is this going to come out of unbudgeted funds? Spend, I guess.
It would be a budget increase. So I can answer that question.
Okay.
Yeah, we didn't have the information back from the assessment to be able, I just wasn't comfortable in putting it into the budget until I knew where we were at and what we were going to do. Do we have anything set aside? We do not. One is each clinical organization is different. And I could get Ingenuum's idea of what to spend on an organization, but I don't know what the will of the organization is. And so I really wanted the organization themselves to help drive this and to make sure that we're doing what is right by the organization itself. And so, and bringing them along the continuum. Like I said earlier, Ingenuum may say they need all these services, but the organization says, yeah, we can only handle X, Y, Z. So really personalize it for the clinical. For the community, there was just so much other than having the initial conversation with Tim Dillman out at the library, overseeing the libraries and understanding their new funding they received. That's the only conversation I had. And as soon as we know what the board's going to do, I'll be meeting with his organization to see what our next steps are for the library, but we'll also be looking at other entities within the community of what we can do.
Oh, thank you, Wendy. I think on behalf of one of the organizations that would hopefully participate in this, we have so far, any money is helpful. So thank you.
Thank you. Any other questions?
I would maybe encourage even within the budget to have a level of flexibility depending on number of uptake of clinical organizations in the community so that we can flex a little bit. If we find that a little bit more than 500,000 is needed for the community or vice versa, so that we're not stringent and we can adapt within that aspect of it. Because creative things like Jesus has mentioned could be piloted, like the farm worker component. That's not at top of our mind right now, but could could be as we go through this process more.
Any other questions?
Wendy, I have a question. Joey had brought it up and it says telehealth is part of the chart model. So is that also including their having like the patient portal piece?
I'm not familiar with the specifics of it, Penny. That's something we would have to dig into. I can say, and I will expand on it more offline with you. I don't want to go down to a rabbit hole too much today. There are two things with funding. There's funding with behavioral health services have been made permanent even after the emergency ends. And then there's funding for the physical health providers that are through 2023, which I understand the reason why they did 2023 is they don't have enough evidence to support the outcomes of it. But they've extended it because they have already started seeing the positive. They just need more evidence, and they're allowing organizations to build the argument of telehealth. However, this will all be a moot point when we all move to a value-based payment, if you will. I know rural health clinics and FQHCs are going to be a little further behind than our the primary care payment model that's coming. But I've had the conversations with the state. That payment model, they're going to start to align some of the FQHCs contracts and RHCs, which are predominantly governed by CMS, which is federal. So the state doesn't necessarily have any say on it. But there's going to start to be some alignment as it pertains to value-based payment. So you're going to start to see that transition, and it's just about providing care and not always about how they're going to be reimbursed. But we can talk more about it offline.
Okay, sounds good.
Kathy, you have your hand up.
Wendy, I just really appreciate seeing schools included on the list as a potential partners in this. And I'm wondering if there was any specific type of service model that was being looked at in regards to the type of telehealth services that would be looked at in schools, or if this is just a very general idea at this point.
So two things. It's a general idea at this point is the short answer, but we do know we have an organization, a clinical organization who is providing telehealth services currently and is wanting to expand that. And if we really want to focus on community, then we should be looking at the schools to say, what do you have? And if we're going to be supporting the clinical organization, then we need to look at the schools and say, what do you have and what do you need to make this program successful? We have not engaged it because one, I wasn't sure where the board was going to go, but two, we're really moving towards that distributive leadership model. And I really would like to take it back and talk to the schools. It's not something that we as an ACH really want to make that decision. We need to make that with the stakeholders at the table. And
Correct.
so, right. And so if we're really following what we've been talking about these last 3 months, that is how I would like to roll it out. We'll see where where you guys decide or land, and then using that distributive leadership, distributive action, distributed decision making, and we will roll it out in that fashion.
Okay, thank you.
Anyone else? Okay, so then my last slide is the staff recommendation that there be a motion to approve the $2 million to support the build out of telehealth infrastructure in the North Central Washington region. Molly, I'll turn it over to you.
Sorry, I was having an unmuting issue. All right. So everyone, on pages 21 and 22 of the board packet is the board decision form. And I hope that you all had a chance to look at.
So
John,
Wendy,
we're going to.
Go ahead, Jesus. I
I
think
was
you had a
just going
comment.
to make a comment that I guess my assumption, Wendy, is that we're approving this and then as the initiatives get defined, there will be other approvals to more specifically allocate those funds to the various modalities or implement applications that are probably going to be pretty diverse. Is that, am I correct in assuming that?
John, do you want to take that one? Or you
Yeah,
want me to?
I think the assumption is that we would continue to update the board. If you approve as is, we would continue to update the board on any major shifts and what's going on with the telehealth work, but we wouldn't come back for any specific approvals, the way it stands. So, but, you know, as we're developing those modalities, we would continue to seek feedback from the board just to help with any adjustments that would be made to those. Wendy, do you feel like that is an accurate statement?
Yeah, the idea was when we've talked about the governance of the board to move the board to more policy. If we kept bringing these back for approval, it keeps the board into the weeds of everything. And so I've given you kind of the roundabout. If we divert from what I've presented drastically, then definitely we'll come back and ask for approval. Otherwise, as John said, updating as we move along to the frequency or the cadence that the board would like.
My other assumption would be this would show up annually in the annual budget. As Wendy said, it's a 2.5-year initiative. So you would be at the annual budget, you would be approving anything for the next year as well.
I guess what I would love to see is in the various implementations that may come about, some sort of structure, proposal structure that specifies what we're going to do, how it's going to be measured, and so that the board is providing some oversight on the actual application of these funds. Right now, it feels like we're signing a big blank check without really knowing a lot of what's going to come after that. And I think on a very high level, I'm in support of this, but it just feels like we're signing a big blank check.
John, could you bring up the board decision form? Because it does go into some of that in the form itself.
I'm gonna.
John, I'm happy to do it.
You got it.
Okay. Okay.
And Ramona has her hand up while I
Yep.
pull up the form.
All right, then I'll let everyone look at it.
Ramona, do you want to comment? Or is it in alignment with Jesus' questions or comments?
No, it's a little different. So why don't we look at this and then I'll speak afterwards.
Sorry.
So not only the purpose was to review investment options for building the telehealth infrastructure and have the board adopt a specific strategy and funding amount, which would then be the 2 million. But then in the proposal, it does sort of break out what the funding pieces, not by dollar amount, but by
Can you go back?
project.
Jesus, could you give kind of an example of what you're thinking? Just
Well, each of those bullets are, to me, are very non-specific in terms of what's going to be funded, with what are the intended outcomes, how are they going to be measured, and I suppose those would come later when we actually have specific implementation of this or applications of this. Those 3 points. Those 3 points are pretty general to me.
Yeah. Even up onto page 22 at the top.
So are you thinking, like, I think what I'm just trying to get clarity in my head, because it would be tied to the motion, like, can you give an example of what would come back for approval when you bring that up?
Well, let's just take the library system. So if you come back and say we're going to do a contract to put various technologies, kiosks or whatever, and we're going to do this much advertising or marketing or promotion, and these are the players, and more that kind of a then I know, like, okay, that I know we're funding, right? And that's just me. I mean, if the rest of the board's comfortable with this level, and that I'm okay, but to me, it's very,
I think I'd absolutely like to earmark $2 million towards this work. And can they come back with, you know, here's how the spend is, or something like that. I don't know that I want all the details of certain things, but I definitely think we should, as a board, discuss and hopefully agree on earmarking this types of funds for this purpose, as Wendy's outlined.
And Wendy also, she had mentioned the clinical organizations would get 75,000, a rough figure. So, I mean, there's some calculations that have been going on. So kind of along with what Rosalinda was saying.
But and like I said, I think it'd be helpful to see how the money gets distributed, but do we need to make each of those distribution decisions? I don't know, that's a lot of decisions. How does the rest of the board feel?
Well, this is Kathy, and I, of course, love the idea of telehealth, and think it would be a great thing to earmark these funds for that. But I do agree with Jesus and Rosalinda that I would like to see a little bit more data about the rollout of this. You know, you know, how is this going to be done? Because we jump right into the bullets of just giving the funding out to districts, and I would like to see more of the planning process. I think, and how the funds are going to be distributed and how sites are going to be selected. Not in great detail, but just a little bit more information about how the budget is going to be spent to ensure that we have a successful program and that there's enough funding, because it could be that we actually need to earmark more funding than $2 million. So it would be nice to be able to see that.
So would I go ahead, Carlene? I have a thought, but.
I'm agreeing with all of these guys as well. I would love to earmark 2 million, and then I just like I like that bulleted of this is where it's going to, you know, I'd like to see where it lays out in terms of the counties and just the feel of it. Because as board members, we do get asked these kind of questions down the road, and it sure is helpful when we know up front. And we don't have to be quite so general, but yes.
Yeah, and my thought process is, it sounds like it's just like another layer deep where maybe you don't have like the application details and like detailed budgets, but you kind of know in a sense, you know, it's going to be focused on schools or this and this, you know, like, so you kind of know. I don't know if I'm getting this right, but you kind of really know what kind of organizations it's getting allocated to, or the type of telehealth initiatives.
And in what amount exactly, John, for me, you know, so I know that, yeah, if this area is getting 15,000 or this is getting 75 or whatever, at least I understand and know and throughout that.
This is Nancy. I kind of like the idea too, because although you could divide it and say every organization needs 75,000, maybe the library doesn't need that much. Maybe the library has funding that's already supporting this project and they won't need that much, and somebody else might need more. So and that's not a decision I want to make all the detailed decisions about that, but just kind of knowing how that works out.
So Ramona, I'm gonna turn to you for your question with your hand up.
Oh, thank you very much. So I agree with everybody. So my question's different, but I'll start with it. I agree with, thank you, Jesus, for bringing that up. I do think you were spot on kind of what a little bit more accountability that needs to happen. And, you know, so I would like to know, you know, what they're planning on doing with it and how much they need, and then, you know, take a look at how it lays out per county. And then my other question is simply, I don't know if it would be a conflict of interest at this point, because, you know, it potentially could affect or benefit my organization if I need to abstain from a vote, or if in theory that it's, you know, that, you know, the 200 million or 2 million is going out there, that I could vote for it at this and then abstain as each one of our organizations come off. I don't know. I don't know how to do that. I just want to say there could be a potential conflict of interest.
Thank you, Ramona, because I have the same thing, because I am on the North Central Washington Library Board. So I don't know if that's a conflict of interest in voting on this whole piece.
That's
And
why I
I'd say-
suggested the earmarking, so we wouldn't have to get into the weeds of each of our organizations getting conflict. Yeah.
And I would say that I think just about everyone on the board, except for probably Senator Warnick, would have a conflict of interest. A potential conflict of interest, depending on how we divide it. Can I ask for a point of clarification? Because I heard a couple of different things. I heard that that you want more information on how we're going to expend this, but you don't want to approve every little detail of it. If you earmark the 2 million for this over two, let me just remind you, it is over 2.5 years. Is it something that I could bring back every quarter, an update of where we're at, where the distribution of funds is, the plans, even some of the outcomes? We are looking at how can we measure this to show outcomes of its success, so you can kind of see where we're going, and then you can help drive that ship at least quarterly, and we can pivot if we need to pivot one way or the other. And then if you're earmarked it, I'm not sure how much more approval you're wanting, or if you want me to bring back each time, or how, because I would say that this was rolled out over 2.5 years, that that could be, as Rosalinda stated, a lot of approval based on when clinical organizations are ready to jump in, based on when community organizations are ready to jump in, and how we all tie it together. So just a little guidance would be helpful.
So Wendy, in my opinion, it's about stewardship, that we have responsibility over these funds. And I think we're all in agreement that we want to approve this earmarking this amount of money for this purpose. I do think that maybe the next step is to come up with some type of set of parameters that will follow, because we could be criticized later for, you know, putting more money in one county or the other, or in one sector or the other. But if we create some parameters that says, you know, we're going to consider whether there's other funding that's going to be complementing this investment or not, and what is some sense of return on the investment, right? That that can be assessed. Something around some sort of parameters like that. I think we could be in a position to respond to any critique pretty well in terms of our stewardship. So I'm thinking then once we approve this, coming up with some type of framework for how some sort of criteria or how we're going to assess the distribution of these funds in terms of its impact and its intent would be a good way to proceed.
Could we do, Jesus, to your comment or suggestion, would be worth getting maybe a small group of board members together over maybe the next month, month and a half, not to push it, to just develop those parameters, and maybe we can approve the earmarks today and then bring those parameters back as almost like we said, maybe that next layer deep, to give you guys a good sense of how the funding is getting distributed, where it's not, maybe we don't have contracts with X, Y, and Z, we're going forward with that, but we know that we're not, we know within the telehealth component, we are going to be doing this kind of thing. I don't know if that seems like a good idea.
Something like that makes sense to me, but I'll defer to others' thoughts.
John, can you bring back up the board decision form, page 2? And then I just wanted to have everyone look at timeline And if that needs to be maybe strengthened, or if that is what Jesus is getting at. As
And
far
Rosa,
as,
you were going to comment too.
Well, if we had our finance committee, darn it, this is where this work would happen.
yes.
Correct. And I
So-
have to have Kat Latte, who's hiding, who asked if it went through the finance committee. So
Yeah. I just wanted to point out that this does say that NCACH staff will develop a process to distribute the funds, ensuring that the goals and the budget align with the intent of the governing board. So they sort of touched on that in this decision form. So I wanted to bring that up to see if
In
it's
lieu of
stronger.
a board work group, I could also develop criteria and bring it back to the next board meeting. I say I, that would be the royal I of ACH staff. Should be the royal we.
This, as far as I'm concerned, that would be the preferable way to do it. I agree. This is still too open-ended. I mean, you could potentially, even with this format, give it out to four different groups, all in the same county. I mean, even though it's not necessarily our intent, but anyway, I just would love a little more around it. Yeah. But I'd love to pass earmarking 2 million today though for this.
yeah.
Okay, so
Before we move past that though, I would actually ask if there are board members interested. I know Wendy said she would take it back and develop it, but it would be nice that that the team doesn't do it and not hit the mark correctly. So if there's 1 or 2 board members who would be interested in being part of that discussion, it would really help get us set up for the next meeting.
I just think that might be challenging because most of us, it's a conflict of interest.
Mhm.
So if we're a part of the decision making, how do we access the funds?
Good point.
yes.
Point down. So I can develop, we can develop, making sure I say we and my colleagues hear that we, criteria and bring it back to the next board meeting. We will do the best we can, recognizing that it's a very fluid, and Carlene, I do hear you. I do hear what you're saying and recognize that. And I hope that the board has trust in the staff that is not what we would do. I'm very much a stickler of, you can ask the rest of the staff, what about Okanagan? What about Grand? What about the smaller community? Making sure that things are distributed in an equitable way.
And I'd be willing to offer, since I'm not part of the medical community here, to just, if you want to email it to me, I do not have enough time to be on a committee to officially do this, but if you want to just send it to me and make some comments, I'd be happy to do that.
Thank you.
Senator Warnick, you unmuted.
Yeah,
don't know if
I
you're-
did. I'm trying to talk myself into volunteering just like Carlene did. I would be glad to look at it as well. So I don't know if you need a motion to, to accept the recommendation, but defer action on the distribution of the funds. Do you need a motion to do that for us to decide today? But I'd be glad to participate as well as Carlene.
Thank
So
you,
I'm happy
Senator
to
Warnick.
move approval of the proposed funding proposal.
So Jesus, you have approved, or you have a motion to approve?
Motion. Yeah, I'm making a motion to approve
Okay,
the recommended funding.
and I'm looking for a second. Senator Warnick, do I have?
I'll second.
Okay. It sounded like you would be doing that, yeah. All right, up for final discussion. Any other questions?
Do we want to add the language that Senator Warnick gave but it was very eloquent at the very end of it, of holding off on release of any funds?
I'm happy to add that language
All right,
in my motion.
okay. Holding off of additional funds until they develop a process to distribute.
That sounds good. Thank you.
All right. So I have a motion to amend and approve and a second from Senator Warnick. At this time, I'm going to call a vote. All those in favor, say aye.
Aye.
All opposed would be nay. Any abstentions? We all abstain. Any abstentions? None?
There is one. There is
There is one. Very good.
Pat is going to abstain from the vote.
All right. And with that being said and noted in the minutes, motion has carried. And so I want to thank everyone. This is a lot that we've gone over.
Well, and thank you all. Sorry, Jesus, to press on the details, but we wanted to, sometimes we hear and then we get wrong. So we wanted to kind of make sure we were clear on what we were bringing back to the board. So thank you.
All right. And it looks like part of the agenda would be a roundtable, but I don't think we really have the time. We only have just a few minutes left. Does anyone have anything that they just need to let the rest of the board know? At this time, I would open it up for any yes, Teresa.
Yeah, just a quick update from public health. As you heard earlier, Chelan Douglas Health District has expanded their board per the requirements of House Bill 1152. And Grant County Health District has just opened up their application process. And I believe Okanagan's going to, in the next month, be opening up theirs. And a number of you and your organizations fit within those categories. So just trying to get the word out as broadly as possible. You can go to our website, granthealth.org, to take a look at the application.
Thank you. Thank you. Yes. Anyone else have anything to add? Our next board meeting is May 2nd at 1 o'clock. So I believe that earlier in the meeting, we went over all the other calendar items. So I will go ahead and adjourn. I have 3:29. So thank you, everyone. Happy Public Health Week.
Thank you, Molly.
Yeah, thank you, Carly. Bye-bye.
Thank you.